Hey guys, this is the lecture for chapter 33. I was really hoping to show you the PowerPoint at the same time that I did the lecture, but two computers that I have are not working to pull up the PowerPoint, so I'm going to have to do it this way. So I hope you all are doing well and staying safe, washing your hands, and using hand sanitizer, and remember your 6 feet distance. Okay, if you pull up your PowerPoint, and you might hear me talking to Kaiten because she's helping me. But if you pull up your PowerPoint, it'll be for chapter 33, patients with upper GI disorders. Move on down to the first slide, which is anorexia. Anorexia is simply the lack of appetite. We a lot of times when we think of anorexia, we actually think of the disease process where someone refuses to eat. But anorexia is actually a generic medical term, which means lack of appetite. There can different things that can cause it. It could be due to certain smells, illness, or anything like that. We just have to be careful with dehydration. The next one is nausea and vomiting. You guys all know what nausea and vomiting are. Different things can cause nausea. It's the urge to vomit, and nausea is subjective. It comes from the patient. I can sit here and look at Kaiten, and she can tell me that she's nauseous, but I can't prove it. She can even make herself retch, but still yet, sometimes you'll retch when you're not vomit. So nausea, again, is a subjective. Vomiting is expelling stomach contents. It's actually a protective measure in the body. If you think about it, if you eat something that is contaminated and you could have food poisoning, the first thing you want to do is have the urge to vomit. So vomiting is a protective mechanism. And I'll let you catch up to me. Now, if you think of, like I told you guys, the body doesn't like old blood and it will make you vomit. And when you vomit old blood, it does look like coffee grounds. Some of you all have already seen this and experienced it, but it definitely does. There's actually even a smell to it as well. Ways that we can help somebody who's vomiting or nauseous, you can actually give them sips of ginger ale. It has been proven to work. Cool washcloths to the head will sometimes help, even being in a cool environment. If you have a patient that is unconscious or they're unable to turn or help themselves and they do start to vomit, you want to turn them on their side. That'll keep the vomit from going back down and aspirating. Okay, so the next, shut up. So that talks about therapeutic interventions. Again, we want to protect the airway, IV fluid. Sometimes you guys will have to put down an NG tube. The next one is obesity. This is hard to do, guys. I mean, it's hard to talk in one thing and look at something else for a PowerPoint, then look at your notes. So just bear with me. Obesity, this is where the caloric intake is greater than the energy that's expended. In other words, you take in more calories than what you use. It has been proven that people with a larger waist, women with a waist greater than 35, men greater than 40, do have a greater risk of health problems, including heart disease. You all have learned about BMI and nutrition, so I'm not going to go back over that again, other than to tell you that morbid obesity is BMI greater than 40, which equals to 100 pounds overweight. Now, there are other problems that can make someone have obesity, and this would be like your metabolic and your endocrine problems. We've talked a lot about that in class as well. It says comorbidities or other problems that you can have with obesity, gallbladder disease, and usually they see a lot of women over age 40 who are obese who have gallbladder issues, heart disease, hypertension, and sleep apnea. And with sleep apnea, studies have shown that people who have a thicker neck will sometimes suffer more with sleep apnea. They could also develop type 2 diabetes and depression. Therapeutic interventions, weight loss. Again, you help set diets and see a nutritionist to help with that. Support groups, behavior modification, and we've talked about hypnosis for weight loss or to help with weight loss. There is a proven success rate with hypnosis and weight loss. However, when all else fails, there is surgical management for weight loss. There are criteria that you have to have for weight loss surgery, and we'll go through it again here in the PowerPoint, but I'm going to go ahead and tell you those. The first one is failure to lose weight on their own. And this has to be documented by a physician that the patient has tried to lose weight on their own and has been unable to do so. The second one is gross obesity for greater than 5 years. So the problem has to be a long-term problem. They have to be psychologically and socially stable. In other words, a lot of them, sometimes their insurance will require them to go through psychiatric counseling just to prove that they are stable. And then the other one is they have to have a medical condition in which they feel that the surgery will benefit, such as hypertension or diabetes type 2, one of those. So again, some of the things they'll have to have is failure to lose weight on their own, and we'll go over some more. These are just some of the ones that I highlighted. Gross obesity greater than 5 years, psychological and social stabilization, and they have to have a medical problem that can be helped with the bariatric surgery. Now, when we refer to surgery for weight loss, it is called bariatric. The different types, the first one is restrictive, and I'm sorry guys, I need to tell you when I'm switching PowerPoints. This one is under obesity. It says surgical management. The first one is restrictive, limits how much the stomach can hold. Malabsorption decreases caloric nutrition absorption and combination. The first one that we talk about in the next PowerPoint is adjustable gastric banding, and the next slide will actually show you pictures, so we'll go on down to the next slide. The adjustable gastric banding is a silicone band, and it's around the upper part of the stomach. The next one is your gastric bypass, or your Roux-en-Y, and this reduces the stomach size and bypasses into the small intestine. Bypasses the small intestine. I'll get it straight here in a minute. And I'm looking on page 640 in your book, and the Roux-en-Y is the gastric bypass of successful weight loss surgery that reduces the stomach size and bypasses some of the small intestine, which reduces absorption of calorie, causing weight loss. So that's your Roux-en-Y. In all honesty, in the past, they used to do more Roux-en-Y than any of these others. Gastric plication folds the stomach inward on itself, and then they suture it. That reduces the amount of food that the stomach can hold. And then the gastric sleeve. To be honest, this is the one they're doing most common. It removes 75% of the stomach and leaves just a sleeve of stomach that's in place. That's how you can remember that. They do have complications with any of these surgeries, such as vomiting, erosion of the gastric tissue. This is the next PowerPoint slide. Breakdown of the staple line, leaking the stomach secretions, infection, and death. One thing that is not mentioned here as a complication is psychological. You know, in America, we eat not just because we're hungry, but we eat for pleasure and we eat for socialization. So there are times when people do have these surgeries and they can no longer participate in certain social activities or things like that, that they really do become depressed. I had a friend who actually worked with me at Bluefield Regional, and she had the surgery done, lost all kinds of weight, and me and her were talking about it. And this was when, right before I had went to Bowman Gray to see about having it done, and she had asked me not to. She said that she was a much happier person when she was bigger than she was after she had the surgery. And after she told me that, about 2 months later, she actually killed herself. So, you know, that's one of the complications that's not mentioned here, but it definitely is one. The next step is the post-operative care. Clear liquid diet, progress to full liquids and pureed foods, and hopefully can eat regular food at 6 weeks. So that means for 6 weeks it's either soft and mushy or liquidy. That's about all they can take. Also, after post-operative care, a lot of times they'll have an NG tube, and whenever anyone has an NG tube for stomach surgery, most of the time the physicians will order that you flush it with normal saline, sterile normal saline. The reason for this using the saline is to keep electrolyte in balance. because a lot of times if we use a lot of water, like you guys are familiar with, a lot of water will decrease your sodium. So they want us with stomach surgeries to use normal saline to irrigate those NG tubes with. Another thing that they don't mention on here but is in your book is long-term or lifelong restriction of the foods that you can eat. But the uptake to it is you should see significant weight loss in 6 to 8 months. Okay, the next slide on oral health care. We've talked a whole lot about oral care, guys. You know, how it can help you from getting pneumonia, how it can help our ventilator patients. We talk about it. A lot of times we don't practice it like we should. Not saying we don't brush our teeth. It's just that we may not take care of our patients' oral care like we need to. That's one reason why I stress to you guys so much when we're in clinicals to make sure you do good mouth care on these folks. There is a definite link to good oral hygiene as well as good health. So they have proven that. So it is something that we definitely need to emphasize to our patients. There are different conditions that the people can develop as far as their oral health. One of the ones I want to mention, and it's on the next, nope, they didn't list it on here. Yes, they did. If it goes on down to oral inflammatory disorders, the first one, apothos stomatitis, these are just canker sores. Inflammation of the oral cavity. They actually look like little white ulcer areas inside your mouth, and they are very painful. They're red. Different things can cause these, such as B12 deficiency, folate deficiency, iron deficiency, stress, and even H. pylori can cause those. Also, dental work can cause it. They've proven dental work can cause those as well. The next one that your book focuses on is the herpes simplex virus. And these is cold sores, fever, blisters. They usually come around your lips, but they can go on your chin, on your cheek, around the bottom of your nose, and up into your nose. They usually come with fever, stress, or illness.
Wait, that means you got herpes?
If you have a fever blister.
Ew!
One of the things that you need to think about too is that these are actually contagious. That if you suffer from fever blisters, that is because someone was kind enough to share that with you. So one thing you should always remember, if you do have a fever blister, whether it's just the itchy feeling that first starts or you actually have a full-blown fever blister, you are contagious, okay? So you could easily give that to someone else. The next subject is, or if you go on down to the next slide, and guys, like I said, this is so difficult for me. I don't have anybody here to slow me down because Kaiten thinks as fast as I talk. So good thing you all can replay this over and over and maybe even slow it down as you listen to it. The next one is oral cancer. This is cancer anywhere in the mouth. If it's found early, it may be treatable. Usually the highest mortality rate is when it's found in the throat. The highest risk comes from using alcohol and tobacco use. Didn't need to stress that because we talk about that all the time. Usually the sores are painless, but they can cause difficulty chewing and swallowing and speaking. And when my dad had his did not hurt. He just felt it. He said it felt like a rough patch in his cheek. And when you looked at it, it literally looked like a white piece of cotton had been stuck to the inside of his cheek. How we determine what type of cancer it is, of course, is through a biopsy. Guys, always remember a biopsy is the only one true way to be able to determine the type of cancer somebody has. As far as treatment, we are all familiar with radiation chemotherapy. The one that I want to mention just briefly is the surgery. It's a radical neck dissection. And you guys can see this picture on page 644. They literally start at the bottom of the neck and they come up the neck up into underneath the chin. With my dad, they had said that for him to have been able to undergo this surgery, they were going to have to remove his mandible and replace the mandible with a synthetic one, and that they would be doing all this work and he would end up with a trach. With my dad's underlying health conditions, he wouldn't have survived the surgery. This surgery is very, very extensive. I do not know of a surgeon here in our area that will actually do a radical neck surgery or dissection and going in. Usually, we have to send them somewhere else. Esophageal cancer is the next one that we talk about. If you're going down to esophageal cancer, usually esophageal cancer is detected late, just because the lymph nodes are so close that usually that's how we find it, is through the lymph nodes being swollen, and by then it has already metastasized. Again, your risk factors are alcohol and tobacco, being overweight, and Barrett's esophagus. Barrett's esophagus happens to folks who have GERD. What happens is the lower esophagus will get really irritated, and actually it develop a stricture from the inflammation. And usually the only way we can diagnose this is with an EGD. So that's Barrett's esophagus, and it is listed on your power slide. Signs and symptoms: difficulty swallowing, feeling of fullness, a bad breath. Guys, always remember cancer smells bad at all times. It doesn't matter what kind of cancer it is, there's always an odor to it. And these folks also have trouble, and they will vomit quite a bit. So that's esophageal cancer. Barium swallow, that is simply where you will drink barium. They're able to look at the contrast in the esophagus. Again, biopsy, the only true way, and an EGD. Therapeutic interventions, this would be radiation, chemotherapy, and surgery. You remember, if they do remove your esophagus, guys, that patient can no longer swallow. So they will have a PEG tube in place, which is another surgery within itself. But they usually do the PEG tube placement right when they do the esophagectomy.
I wouldn't be able to stand that.
Huh?
I wouldn't be able to stand it. So they can't eat food?
No, they can't swallow. The esophagus is
Well,
gone.
that would suck. How are you supposed to, have a good...
No, they can't.
That's my favorite thing. I'd cry. I wouldn't be able to make it.
Oh, you couldn't cry because you can't swallow your tears. Hiatal hernia. And this is, if you look, these, I'm on page 644. And we're talking about hiatal hernias. There's two different types. There's a sliding hiatal hernia and a periesophageal hiatal hernia. A sliding hiatal hernia is the lower esophagus, or the stomach slides up through the diaphragm. And if you look at the bottom of the page, the first picture shows it normal. The second picture shows where a part of the stomach has slid up through the diaphragm. And then the third picture shows what they call a rolling hiatal hernia, which is very rare and it's dangerous. The stomach actually stays up in there and can actually suffocate or form a stricture. So that's the three different, that's normal, and then sliding, which is the most common, and then the paraesophageal. If you look straight across the page, this is one of the ways that we fix hiatal hernias. This is called a Nissen fundoplication, and this is really actually pretty cool. What they do is they take the upper part of the stomach, the fundus, and they just wrap it around and attach it to the other side of the stomach. This is actually, believe it or not, it looks like it's a pretty simple surgery, but in past times, not as much now. There used to be a lot of diaphragmatic problems, like the diaphragmatic nerve would get injured, and these folks would be on the ventilator permanently, some of them, and some of them it would be just slow to reactivate the diaphragmatic nerve. But there did used to be a lot of trouble with that. But this is called a Nissen fundoplication, and the bad things about it is when the folks have this, they can no longer vomit. It keeps, how the Nissen works is it keeps, you can turn the heat up, Kate. How Nissen works is it keeps food and substances from an acid from riding it back up the esophagus. If you can see how it's pulled around, it's tight. So food and other things cannot regurgitate back up, but the patient can no longer vomit either. They will retch if they're nauseated, which is a terrible feeling, but they cannot vomit. Also, these folks have a hard time with burping. Most of them actually cannot burp after they have this done because nothing can pass upward through that once this is done. Now they do it usually with a one-night stay, but when they first started doing it, it took quite some time to be able to get it done. The people who are at risk for hiatal hernias, again, obesity, those over 50, smokers, and those who are pregnant. The next one we talk about is GERD, which is one that most of you all are really familiar with. Oh, let me back up a minute to hiatal hernia. There is something I didn't mean to tell you. With hiatal hernias, other things that we can do to help them is tell them to eat small, frequent meals. That way their stomach does not overexpand. They want to keep the head of their bed raised 4 to 6 inches, or the PowerPoint says 6 to 12, which is even better. We want them to avoid eating 3 hours before bedtime, so that takes care of the bedtime snacks. No spicy foods, avoid alcohol and caffeine, and definitely quit smoking. Now, I'll be honest with you, I am not sure of the correlation with smoking and a hiatal hernia. I haven't figured that one out yet, and that's one of the ones I need to look up. They do list it as a risk factor, but I'm not really sure how.
Don't they get the munchies or something?
No, that's if
Oh,
they
that's a
smoke.
weed. Oh, never mind.
No. Having Kate in here is kind of like having some of you guys here. Nursing care, again, just we want to make sure that we keep an eye on the patient with a hiatal hernia. This includes their meds too, and there's certain meds like doxycycline that, which I didn't learn until the past couple of months, that you're not supposed to take it within 3 hours of going to bed or laying your head down. Because it could cause some erosion. They don't want you to lay down at all 30 minutes after you're taking it, but that is one of the ones that can cause severe esophageal erosion. So that's pretty interesting too. All right, now back to GERD. Gastroesophageal reflux disease. The esophagus becomes damaged. If you've ever had GERD, and I'm sure most of you all have, that's when acid will come up in your throat, or maybe some food will come up in your throat. Most of us do have these problems just because we don't practice proper lifting techniques, and we can actually cause the area that the diaphragm to widen and the esophagus to widen, and that's how this happens. But over time, and like I told you guys, like at nighttime, you'll aspirate at night, and with GERD, and when you aspirate at night, quit, Caton. And when you aspirate at night, I'm sorry, guys. Like I said, having her here is kind of like having some of you all here. When you aspirate at nighttime, and sometimes you're not even aware of it, you'll wake up coughing, and this is silent aspiration, and it is still true aspiration. So these are some of the symptoms. Heartburn, and guys, sometimes with GERD, it actually feels like you're having a heart attack, especially if you've had a little bit of reflux with it, because you can't breathe, your chest hurts. Also sour taste in your mouth, dysphagia. We diagnose this through a barium swallow, EGD, pH monitoring. And what they mean by pH monitoring, I've actually seen this and had patients who've had it. They'll actually take them and do through an EGD, and they'll actually place like, for lack of a better word, it's like a small tube that goes down into the stomach, and it goes into the stomach, it lies along the esophagus, and then of course it comes out the nose like an NG tube, but it's real thin. And after 24 hours they go back and they pull it, and when they pull it, they're able to see how much acid has gone up by looking at the pH on the strip. The strip is like a pH scale, so it is pretty interesting. Complications from GERD, again, asthma, aspiration pneumonia, bronchial spasm, laryngeal spasm, and Barrett's esophagus. And again, this is where the lower esophagus gets really irritated. They do consider it precancerous. Let's see. Now we're talking about Barrett's esophagus. Treatment for Barrett's esophagus, they go in and they actually do ablation through an EGD. Therapeutic measures to help with that is lifestyle changes, antacids, 8 histamine 2 blockers, PPIs, which you guys all know. PPIs are proton pump inhibitors such as Protonix, and you have to monitor what electrolyte, Aaron? That's right, magnesium. Got to keep an eye on your magnesium level with those. I'm just looking through here. Let's see. Let's go on down to, let's see, I told you guys about elevating the head of the bed, and complications of GERD are esophagitis and Barrett's esophagus. Again, lose weight, eat low-fat diet, avoid caffeine, milk products. All right. Now we're on Mallory-Weiss Mallory-Weiss, we had a patient last year that the students got to go in on an EGD, which you guys really haven't gotten to do yet. And they actually saw the Mallory Weiss tear and was able to see one and had a picture. It's a longitudinal tear in the mucous membrane of the esophagus at the stomach junction. So longitudinal means which way? Up and down. That's very, very, very rare because normally the tears are latitudinal or side to side. So longitudinal tear. The tears are sudden and powerful or prolonged force is what causes them. A lot of times it could be, this would be Greg calling. Tears from I'm sorry, let me get back where I was at. Something strong and powerful and sudden can cause the tear. Hiatal hernias are present. Signs and symptoms: bright red bloody emesis, and emesis again means vomiting. Bloody or tarry stools, that's just where the blood has happened to have passed down and through the intestines. EGD, we treat it, it usually heals itself, but we do got to protect the skin around it, and that's what the tissue, I shouldn't say skin, the tissue around it, and we do that by giving PPIs, antiemetics, and sometimes they'll go in and clip the tear together and to hold it. Definitely avoid alcohol. Alcohol is so irritating to the mucosa of the stomach. The next one, esophageal varices. If you've had a patient who has had any type of cirrhosis, hold on just a moment. Okay, esophageal varices, if you've had a patient with cirrhosis, and we will talk more about this in the next chapter, what it is, esophageal varices are simply varicose veins in the esophagus. If they do rupture, like I've told you guys, it can be life-threatening. Most of the time, there's not a whole lot we can do about it, but we will talk about it because we can do, you guys have no idea how hard this is. We can place a balloon down the esophagus, and that will actually help take care of it. But patients with cirrhosis are usually the ones that we see this. Gastritis, this is just inflammation of the stomach. It can be acute or chronic. Abdominal pain, nausea, again, anorexia. What we have to do is try to give them antacids, PPIs, Pepcid, those types of things to kind of help with it. What happens is the protective mucosa barrier breaks down, and literally gastritis looks like has a salt pepper appearance when you see it on an EGD. If it is severe, it can actually cause a perforation of the esophagus, which is almost impossible to repair. It can cause scarring. Therapeutic interventions: treat the cause. Definitely avoid alcohol, irritating foods, which is usually your spicy foods. Give antacids and antiemetics because vomiting is rough on your stomach. Now they divide, this is new, this is all brand new, they divide gastritis up into two different types. Type A is autoimmune, and again, you guys know autoimmune is, that's right, body attacks itself. Usually it's found in the fundus, it can be asymptomatic, but it can lead to pernicious anemia. And with pernicious anemia, we know that is due to lack of what vitamin, Caton? What vitamin? No, not iron.
Just kidding. Anemia?
Just kidding. No, not any pernicious anemia. Future doctor material here, guys.
Well, I wasn't paying attention to your lecture. I don't know.
B12, guys.
I was getting ready to say B12. I was.
Yeah, right.
I swear.
So gastritis can also cause pernicious anemia, which is a lack of B12. Patho, usually H. pylori. And H. pylori, when we do treat H. pylori, they usually give a triage of medications. It's usually Pepto-Bismol. I know that sounds weird, but the bismuth in Pepto-Bismol is really good to help with it. And usually take a PPI. And then you also take an antibiotic. Now, for everybody, the antibiotic is different. The one they use most often is erythromycin, but there is a triage of medications that we use for H. pylori.
Where's my darn jeans?
Now, stress-induced gastritis. Stress ulcers. Oh, wait a minute. Let's back up a minute, guys. I'm sorry. Let's go over this again, okay? Forget that I said that part. Chronic gastritis is autoimmune. It's in the fundus. It's asymptomatic and can lead to pernicious anemia. Kaiten got me all messed up. Gastritis type B comes from H. pylori infection. It's the lower stomach and can cause heartburn, a sour taste, and we treat it with antibiotics. So please review those 2 slides again to know the difference, because I messed you up thanks to my beautiful daughter. Stress-induced gastritis. These are stress ulcers. Critically ill or at risk. Now, the reason why the critically ill are at risk is because you think if you have gotten a critical ill, Kate, put your mess up over there. If you have gotten a diagnosis of being critically ill, then that definitely is a stressful time. Ischemia damaging the mucosal barrier. Acids can cause ulcerations. And we treat this again, you see it says on there early feeding. With stress-induced ulcers, we try to keep food on the stomach. That actually helps with the erosion. Prophylactic antacids and histamine blockers. And you'll see a medication listed there as sucralfate. We know this as Carafate, and this is the one that you have to melt down to give to your patient, because if they swallow it, they take a chance of choking because it does swell. Just a little tidbit there. Peptic ulcer disease, erosion of the gastrointestinal lining. It can be curable, usually caused by H. pylori. Increased risk, again, smoking and NSAID use. Guys, NSAID use is really, really becoming a topic of conversation, especially right now with the coronavirus. They're saying NSAID use will actually make the coronavirus worse. Put that stuff up, Kaiten.
What's NSAID?
What's NSAID?
Mm-hmm.
Non-steroidal anti-inflammatory.
Okay.
Like ibuprofen, aspirin. Complications include bleeding, perforation, and obstruction. Urea breath test. I've never seen them use urea breath test. That is one that they do in the office, but I have yet to see them do that. The way I've seen them usually do it is they will draw labs. That's the look for the H. pylori in the lab, and they'll do. It says on here an EGD or an upper GI series. Therapeutic interventions, again, antibiotics, because we're looking at H. pylori. PPIs, H subscript 2 antagonists, bismuth, that's your Pepto-Bismol, sulfate or Carafate, and antacids. We want to avoid spicy food, smoking, caffeine, and alcohol. And let me see if there was anything else I had written down there for you on that one. Nope. Okay. Gastric bleeding. Gastric bleeding comes from an ulcer, a tumor, or gastric surgery. It can be occult. If something's occult, what's that mean, Kaiten?
It's like you're like a group of things.
Occult. Not occult. Not C-U-L-T. It's O-C-C-U-L-T.
OCCU.
L-T.
Give it to me a second.
She's going to come back and tell us what occult means. Okay, so they could have occult or observable. The symptoms vary by severity. It could be mild, which the patient would have the symptoms of anemia, slight weakness, diaphoresis, severe hypovolemic shock, weak pulse, chills, and palpitations. Gastric bleeding, guys, these folks can get in trouble really quick.
You can see it.
No, that's not what occult means.
I don't know.
Look it up.
I can't. You got my phone.
Look, there's a computer. Look up occult. These folks with gastric bleeding can get into trouble really quickly. I've seen people that would start just like vomiting a little bit of blood, and then before you know it, they're gushing. And when that happens, you've got to be so careful, because they do get scared and they'll start to want to aspirate just from breathing quick and fast and hard, and plus they're trying to swallow blood. Lower GI bleeding is pretty rough too. Lower GI bleeding, there's definitely a smell to it. It's black and tarry. You cannot have my phone.
I see what it spelled like.
O-C-C-U-L-T.
That's what I got. Okay.
So,
Hidden.
what's it mean?
Hidden.
Okay. So everybody, occult means what, Kaiten?
Hidden.
Hidden. It means like occult blood. You don't see it easily, okay? That would be like your black tarry stools or a positive occult blood. Thank you, Kaiten.
You're welcome.
Therapeutic interventions for a GI bleeder is nothing by mouth. Guys, normally they put down an NG tube, even if it's a lower GI bleed. If it's bad enough, they'll put down an NG tube. IV fluid, catheter. The reason why we want to make sure, since we're going to be, that we're not getting in a deficit or excessive amount of fluid. Oxygen. Think about it, guys. If you're anemic due to a GI bleed, your O2 is going to be low. So definitely oxygen. Make sure there's anything else that I need to tell you about a GI bleeder. Okay, I think that's about it. Gastric cancer. This is a malignant lesion in the stomach. Men are at greater risk than women. H. pylori is a risk factor. They usually have a poor prognosis. Usually by the time that they find it, it has metastasized. Just because the symptoms are all usually things that we have trouble with. Huh?
I know what that means.
Okay. No early symptoms. Late symptoms include indigestion, anorexia, pain relief by antacids, weight loss, nausea, vomiting, and anemia. Usually they find it by x-ray, gastroscopy, gastric fluid analysis, or even serum gastric level. Therapeutic interventions, again, surgery, chemotherapy, radiation. And when it mentions biologic therapy that boosts your immune system, these are the ones that you can take. Usually it's a sub-Q injection that will help with the immune system. If they do have to do surgery, they will either do a subtotal gastrectomy or remove part of the stomach, or total gastrectomy, remove all of the stomach. And yes, that can happen, guys, and these folks can still live a life, even if they have had part or all of their surgery removed. All their stomach removed. The first one, gastroduodenostomy, Billroth 1. The distal part, now distal means further away, part of the stomach is removed. And if you look on page 653, it will actually show you these. They do an anastomosis or connection to the duodenum. Billroth 2, more distal of the stomach is removed, and they do an anastomosis to the jejunum. Now you got to think of what your small intestine. Remember, it's DJI, so duodenum, jejunum, and ileum. Extensive gastric cancer, they do straight to esophagus to the jejunum, and you can see on the next slide, they do take out the entire stomach, and the esophagus is put right to the jejunum. We're going to monitor nursing care. We're going to monitor their vital signs, respiratory status, pain control, definitely INO, NG tube care, and again, usually after surgery, we use saline to irrigate those NG tubes with. And if that patient was to happen to start to vomit blood, one of the first things we need to do, because sometimes that can happen, is just like before, when anybody vomits, we want to get them onto their side. But that is a complication as well. And with any surgery, DVTs can be a complication. Gastric distension, that's why we have the NG tube to help with that. Dumping syndrome. Dumping syndrome is one of those things that a lot of folks suffer with, even post the gallbladder surgery. Dumping syndrome is one of the most common complications. It occurs when the rapid entry of food goes into the jejunum without proper mixing of the food with digestive juices. This is on page 655. What happens is all of a sudden they eat and then they have to go to the bathroom. In other words, dumping syndrome. The symptoms occur 5 to 30 minutes after eating. It's almost as soon as they start to eat, they have to go. They will develop abdominal cramping, that they will develop dizziness, sweating. It's like they really, I guess it'd be kind of similar to a hypoglycemic episode. They also have weakness, anxiety, and this unfortunately is something that they will have to deal with, but it does get better for some folks. And there are medications that are out there now that will help slow, like Reglan, that will help slow emptying time that they can take. But the best thing that we can do to advise them when they first develop dumping syndrome is to eat small, frequent meals. This will actually help with the transit time, because you don't have a whole big chime of food that you're trying to digest, which will trigger it. If you do smaller meals, that doesn't seem to trigger the dumping syndrome as much. Okay, let's see here. Went through the review questions. And that looks like that's it, guys. Let me make sure I've told you everything that I need to tell you. Oh, steatorrhea is one of the, if you look on page 65, and pyloric obstruction. Those are two things I do want to touch on just for a minute. Steatorrhea is the presence of excessive fat in the stools. This is usually the result of rapid gastric emptying. We can sometimes treat that with pancreatic enzymes, and we usually see this with folks who have problems with their liver. Or pancreas, that sometimes that they'll have this. Pyloric obstruction is a complication after gastric surgery. What happens is that the area of the pylorus, it gets really stiff and tight, and the food is unable to go from the stomach to the small intestines. And so what happens is that the patient will vomit a lot, like in a child with pyloric stenosis. The surgeons, for surgery, they can go in and perform pyeloplasty, and that's Pyeloplasty, and this will help to move the food from the stomach into the intestine. So that is a problem that can happen after gastric surgery as well. The dumping syndrome, steatorrhea, pyloric obstruction, gastric distension, and hemorrhage. Those are all things that we can have trouble with. I'm sorry, guys. I hope this helps some. At least you can slow me down on your own now. And like I said, this was difficult for me. Maybe I'll get better as time goes. If you have any questions, please just email me. Remind that my house doesn't work the best in the world. So just email me, and I'll be glad to answer the questions that I can. And we will set up a Skype phone call tomorrow. Let's try to do it Skype at 10. That seems to be a good time for everybody. So we'll just Skype at 10. It's just going to be to review any problems that's happened this week. There's supposed to be a big meeting today with Rosemary and the folks who are at the Charleston. So I will let you update on any of those, any of that information as we need to be. This test will be tomorrow. Everything that is on the test I have gone over in talking about it in this lecture, and like I said, I know I was all over the place. This is really difficult. So just take your time and go back over everything. I think you guys will do fine. And guys, I've had a few of you, just stress to me how you can't do this and how hard this is and everything. What you guys have to remember is you're not in the boat alone. I mean, this is hard for all of us. It's hard for me to teach like this because I don't feel like I'm doing a good job. It's hard to answer everybody. It's hard to grade. It's hard to do all of it. And I know it's hard for you guys too. But unfortunately, in the situation we're in right now, we have no other choice. Some of the other schools that I've looked at, they're not even doing like lecture like this. They're just pretty much telling the students read the chapter and answer the questions. So, which is, another option that we could do, but we prefer to try to have some kind of contact with you guys. The more I hear, the more I'll let you know. So just keep us all in each other's prayers, and y'all have a good day. Thanks.